So after assessing spasticity, the next important question is, how do I actually manage it? First, yes, I do stretching, not because I strongly believe stretching alone reduces spasticity, but because many of my patients genuinely feel better after a good stretch, so that matters. And there's a limitation. Stretching mainly acts on the muscle and the surrounding soft tissue. It may temporarily reduce stiffness, but it doesn't necessarily change the neural drive behind the spasticity. Then comes botulinum toxin or Botox. That's where the PTs play a huge role. Before Botox, I want absolute clarity about which muscle are we targeting, why that muscle, and how much tone reduction are we actually aiming for. That discussion with the neurologist is very important. Botox works by blocking the acetylcholine release, reducing muscle contraction and overactive muscle firing. But it doesn't repair the CNS lesion or strengthen the weak antagonist. And that's where post-Botox rehab becomes important, because when I think of spasticity, there's two components. One is a neural component and one is a mechanical component. Botox mainly helps with the neural component. That's why I often use serial casting after a Botox. Serial casting helps address the mechanical component by promoting tissue remodeling, sarcomere adaptation, and improve passive range. And finally, one thing I'll use a lot is loading and weight bearing. Meaningful load gives sustained sensory input into the system. It improves motor requirement, co-contraction, and can sometimes modulate tone rather than constantly trying to fight it. And at the end of the day, I'm just trying to reduce. I'm not just trying to reduce spasticity. We're all trying to improve the function.